Assalamualaikum. I hope you're all doing fine. I am Dr. Muhammad Ali Rabbani, Assistant Professor of Anatomy, and I'm going to discuss with you the midbrain lesions. This is a lecture, a part of lectures on brainstem. That is a part of a bigger series of neuroanatomy lectures that are available on our YouTube channel. Please go through them, go down Medicose Academics, go through them, find the list below in the playlist in the descriptions below, and if you have any question, please let us know. Before starting the midbrain lesion, I hope you have already seen the video on the anatomy of cross-sectional anatomy of midbrain. If you have not, you can find it in our playlist and the link above. And in that video, we gradually build up to the formation of cross-sectional anatomy of the midbrain at the level of superior colliculus and at the level of inferior colliculus. I'm not going to detail of how to make these. We have discussed in. I will refer you again to that video. So I will start with discussion of syndromes. Medial midbrain syndrome, also known as Weber syndrome. What happens in the Weber syndrome is that the arteries, especially and there is here the basilar artery divides into the posterior cerebral arteries, and the arteries that are supplying the midbrain, these are affected. The midbrain branches of posterior cerebral arteries, these are affected, and due to this effect, this is roughly the area of damage, and that area is including the, let me remove myself, okay, crus cerebri, the especially the corticospinal tract and oculomotor nerve. These are the major part that is affected. So oculomotor nerve fibers, the intraaxial or part of the oculomotor nerve fibers, the part of the oculomotor nerve that is present within the midbrain, that is affected. So all of the functions of the oculomotor nerve are lost. All the muscles of the extraocular except lateral rectus and superior oblique, that includes superior rectus, inferior rectus, medial rectus, and inferior oblique and levator palpebrae superioris, all of these are supplied by oculomotor nerve fibers. When those are lost, then the person is unable to move the eye medially, adduct the eye, and when person cannot adduct the eye at horizontal at neutral position, the eye will deviate towards the lateral aspect due to the unopposed action of lateral rectus, that is called lateral strabismus and lateral squint. I have discussed these mechanics in very great detail in the lectures of orbit and eye, where I have discussed the mechanics of extraocular muscles. You can find that video. Then downwards and outward deviation of the eye is there, leading to diplopia. The oculomotor nerve is also carrying the signals for the pupillary constriction and parasympathetic fibers. So there will be dilated pupils due to the loss of parasympathetic supply. And here, if you remember, the Edinger-Westphal nucleus was carrying this parasympathetic fibers for the dilatation of pupil, and this will also lead to the loss of accommodation reflex on that side. The eyes cannot focus due to the absence of the ciliary muscles. And ptosis will be there due to the levator palpebrae superioris muscle. The upper eyelids will droop down, and you will see the person with upper affected eyelid lower down as compared to the normal one. Corticospinal tract was involved, that will lead to the contralateral spastic paralysis. Contralateral because the corticospinal tract has yet to cross the midline as it go down at the junction of the medulla and spinal cord. So it is above the decussation. So there will be contralateral loss of muscle movement. There will be contralateral spastic paralysis. Corticobulbar fibers. These are the fibers of the cortex that are carrying information to the motor nuclei of the cranial nerves. So those will be affected. As we've discussed already, the cranial nerve motor nuclei are supplied bilaterally, except a few. So apart from those exceptions, no other cranial nerve paralysis will be done. The paralysis will be of those exceptions, and those include lower half of the face and the part of the hypoglossal nucleus that supplies genioglossus. So there will be contralateral spastic paralysis of lower half of the face, and there will be contralateral spastic paralysis of genioglossus muscle. Then there is paramedian or Midbrain or Benedikt syndrome. So this is the area that is affected. That is somewhere here, just paramedian branches of the posterior cerebral artery near here. These are affected. So the three items that are affected here is the oculomotor nerve, red nucleus, and medial lemniscus. By three, I mean the most prominent three that you are going to check in your clinical examination. The loss of oculomotor nerve fibers will lead to the outward and downgoing gaze, diplopia, and lateral strabismus. Fixed dilated pupils due to the loss of Edinger-Westphal fibers, the parasympathetic fibers, and ptosis, the drooping of the eyelid due to the paralysis of levator palpebrae superioris. The medial lemniscus, where my pointer is, it leads to the loss of two-point discrimination, proprioception, and vibration senses from the contralateral half of the body. So these will be lost. Contralateral because this tract has crossed the midline just above the pyramidal decussation in internal arcuate fibers. And red nucleus has very important roles in muscle movements. This red nucleus maintains the flexor tone of the contralateral side of the body, and this communicates with the cerebellum. The cerebellum sends signals to the red nucleus, and red nucleus sends signals down to the muscles. Cerebellum sends signals to the red nucleus, and through red nucleus sends signals above to the cerebral cortex. So when these occur, the communication with the cerebellum is very severely affected. So there will be contralateral cerebral dystaxia with intentional tremors, cerebellar signs. These are because you will, if you again, I will recommend you to go through the midbrain cross-section lecture. You saw that there from the contralateral cerebellum to the dentate nucleus through decussation of the superior peduncle, the fibers came to the contralateral red nucleus. So when red nucleus is damaged, the communication with the contralateral cerebellum is damaged, and the cerebellar features are at the same side as of the muscle. So there will be contralateral cerebellar signs, cerebellar dystaxia, and intentional tremors. There will be a loss of muscle tone issues will be there. So that's what Benedikt syndrome. I think there is a little, some books by the way, Benedict, they'll label it by KT also, some books, but that's something other. Parinaud syndrome. Before going into the Parinaud syndrome, you see the posterior anatomy of the brainstem. You can see there are superior colliculi and inferior colliculi just supromedial to the superior colliculi. This is pineal gland. So if the pineal gland grows bigger due to some tumor or something, it is going to compress the superior colliculi forward. So it is a tumor in the pineal region. It may be pileinoma itself or germinoma, and that leads to this affected area. Superior colliculi will be affected, in front of it pretectal nuclei will be affected, and cerebral aqueduct will be affected. Superior colliculus is, in addition to a lot, there are a lot of functions that it does. The tactospinal, spinotactile tracts responsible for spino-visual and visuospinal reflexes. Spino, visual and visuospinal reflexes are conducted through it. Vertical gaze is managed through it, and there are other functions including communication with the auditory pathway to move the eyes in that direction and so on. So those functions are lost. Especially the most prominent one is vertical conjugate gaze, that is lost. Loss of pupillary light reflex, that is due to this pretectal nucleus. Again, I have discussed this part in the lecture of visual pathway. You can find it in the playlist of head and neck. I can add the description link in the description here too. The absence of convergence, that's not right. Please ignore that. This is by mistake. Pretectal nucleus, it's not involved in the convergence. So let me remove it so that it may not create any confusion. Edinger-Westphal is involved in the convergence, but that is not. Then there is cerebral aqueduct. When cerebral aqueduct is blocked, there is a lack the communication between the third ventricle and the fourth ventricle that is affected, and the cerebrospinal fluid, it flows from the lateral ventricle to the third ventricle through the foramen of Monro, from the third ventricle to the fourth ventricle through the cerebral aqueduct, from there to the central canal of spinal cord and to outside through foramen of Luschka and Magendie, and then it bathes and goes out. So whenever there is a block at any part, the upstream where the fluid was coming from, that gets dilated. So in this case, the upstream is third ventricle and fourth ventricle, third ventricle and lateral ventricle, so they will get dilated. So that is non-communicating hydrocephalus. Cerebral aqueduct can be blocked by other reasons too. Very common cause is congenital hydrocephalus, where congenitally cerebral aqueduct is blocked or it's not present, or it's replaced by numerous small tubular passages that are incompetent for carrying the large amount of fluid that is going on. The tumors in the midbrain, the tumor outside the midbrain, that Parinaud Syndrome we saw. So all of these, and maybe there are other reasons too that may affect the brainstem midbrain. Thank you so much. That brings us to the end of the lesions of midbrain. If you have any questions, suggestions and feedback, please let us know down in the comments. You can contact with us through our social media handles and our email and phone number as visible here. And do subscribe to us and follow our channels so that you can keep up to date with the new lectures that are coming. Thank you so much.